Good afternoon, everybody. We are going to go ahead and get started with today's session. And as it relates to your national exam, one of the things that I just want to keep overemphasizing when we get to the point where I'm going to be giving you quizzes, it's so important that you remember to answer the question based on how we discuss. You need to answer the question for the exam because what you're going to find is if you try to answer it based on your previous experience, you're going to find that you may answer the question wrong. All right, so today we're going to start or focus on the patient intake process. And as I mentioned yesterday, NHA and this test, it's a little dated in regards to some of the concepts that they talk about. But we don't care about that because we are going to talk about some real world things that you need to know in this role. And you heard me mention yesterday when you're looking at jobs, look at patient access, revenue, not revenue, patient access, patient registration, the kind of like the start of the revenue cycle. So the patient intake is that time frame when the patient actually shows up for a service at our facility. And today, because it's 2021, patients are going to be accessing the facility um, where it's very fancy and they have a kiosk that you can check in and say, I'm here. Or there is a person that greets them at the front. In either case, the data that's going to be captured is going to be captured in some type of system. And so there are two terms that you will need to be familiar with. One is an electronic health record, the other is the electronic medical record. And the electronic medical record is generally associated with a small, one location, if you will, organization. Whereas an electronic health record, you're talking about a more larger health system. Um, with an electronic health record, it oftentimes has the ability to communicate electronically with other organizations, whereas the electronic medical record may not have that capability. So when you have a small doctor's office, they probably have an electronic medical record system. There I go putting lotion on again, like I did yesterday. I'll be rubbing my hands together for 10 minutes. This some Avon is some good lotion. All right. So that's enough about that. So the first thing you want to know is when our patient arrives at the healthcare facility, we are going to either collect or confirm. I'm going to say that again: collect or confirm their demographic information. So here is a list of information, basic information that NHA says you should know as demographic information. And of course, it's the legal name of the patient, their full name. And one of the reasons that we ask the patient for a copy of their ID is because hopefully on their ID, their full legal name is there. Now, I'll tell you something funny. On my driver's license and my state ID, my legal name is actually not on there. And it's because up until about 15 years ago, I didn't even know what my legal name was, because I thought my name was Lisa. But it turns out that my legal first name is Lisa Lynette. And so, other than my passport, everything else has my first name is Lisa, and that's what I go by. Um, Insurance company, my first name is listed as it is on my ID. Any bills that I have, same thing as it is on my ID. So, very important to get the patient's full name that's on their ID, and hopefully the name on the ID and the insurance card are going to be exactly the same. If you have a child that we're seeing today, we definitely have to make sure we have the parents' names because we need somebody to pay the bill. And we need to know the gender of the patient, what their date of birth is. Date of birth is always captured as 2 digits for the month, 2 digits for the year, and 4 digits for, I'm sorry, 2 digits for the month, 2 digits for the day, and 4 digits for the year, because you don't want to say 20 as the year that they were born, because is that 2020 or is that 1920? So, for example, my grandfather, who is still living, was born in 1920. So, very important to have that 4 digits for the year. If the patient is married, we're going to have their spouse's name, need their information too. We want to make sure we got multiple people we can contact if we need to get in touch with that patient. And then, of course, their home address. And when I said enter or verify, that was a very powerful statement because before we enter the name, we need to verify that the patient is not already in our system, because we really want to try to avoid having duplicate accounts for our patients, because there have been situations where patients have called in, they've asked if they have a balance, and we look them up and we're like, nope, you don't have a balance. And then the patient's like, but I got this statement in the mail. And so then what we discover is that the patient is in here twice. And so usually what has to happen, we have to merge the two accounts together. Um, every organization has a policy on how that works. Um, Something else I want to tell you. Insurance information, very, very important, because we need to know who is going to pay this bill. And if they can't prove that they have insurance, then they are a cash paying patient. All right. So when we intake our patients, we have to consider that some of our patients may have disabilities. And so when we talk about disabilities, it's important to know about the Americans with Disabilities Act. And the Americans with Disabilities Act basically says there are certain things that we need to have in place. So it needs to be wheelchair accessible. We need to have um, options for patients that maybe if they can't see, we need to have braille. So if they can't see, if they can't hear, or if they can't talk, or if they have some type of language barrier, that we have things in place. So clear signage, braille forms. If you have somebody that is hearing impaired, sometimes noise is an issue for them. And so that's where really understanding our patients is critical. Sometimes we don't know that the patient has these disabilities that require accommodations. Sometimes you kind of learn it along the way. My neighbor, I've lived in my house for about 20 years. I just found out my neighbor couldn't hear. She'd be talking to me all the time. And so apparently she has some hearing aids in, and something happened with her and the next door neighbor and a dog or something. And so I went over to tell her that I had captured on camera, because it's 2021, what happened with her, with the pit bull bulldog from next door beating her dog, biting her dog and biting her. And then she did like this. And I was like, oh, all this time. I didn't know. So she had to go back in the house and put her hearing aids in so I could talk to her. But that was kind of weird because I had no clue. And I talk to this lady all the time. And that's because hearing aids today, they're much smaller. And so I didn't even notice. But actually, in retrospect, um, I realized that also I probably spend more time communicating with her via text message. So maybe I would not have known that. But then also, when I think about how she does speak, I now realize that she does have a hearing problem. So paying attention to patients are critical. So always, always, always check to make sure that the patient is not in the system. You don't know how many hospitals have duplicate records of patients. And so when we talk about building that patient's record, it is so very important that we build the patient's record and ensure that we comply with HIPAA. So we're going to talk about HIPAA a little bit today, like right now, and then we're going to talk about it again under another topic. So HIPAA, the Health Insurance Portability and Accountability Act, says that we have to ensure that we protect the privacy of our patient's record as well as keep the record secure, keep it safe. And so when we talk about privacy and security, some of the things that come to mind for me immediately is that we have to have some type of safeguards in place to prevent people from accessing the records that should not have access to the records. We should make sure that the records are locked. If it's an electronic system, that we have passwords when people are no longer at an organization, that we are disabling their passwords. And funny story, I have an administrative assistant who I'm kind of transitioning out of her job. And so I went in last week and changed her email password and system password in some kind of way. After I called the company that I used to confirm that everything had been changed, she was able to reset the password. So two people gonna be transitioned this month, her and that company, because I'm like, how was I, as the administrator, able to change the password, and then her as a user was able to go back in and change, reset the password. And so I talked to my IT guy, and he was like, yeah, it's the company that you're using, and we got to get you away from that company to another company, because theoretically I should be able to be at home in the bed and should be able to disable somebody's access. Now, generally at hospitals, health systems, clinics, they have more money than I have. And so they have more high-tech systems that can disable. But the thing is, sometimes it'll be, and this is something that I know that I should have in place and didn't, but I will starting June 1st. Everybody got to change their password every XYZ days. And also, I'm switching companies so that I can disable passwords anytime I want to. Because when somebody, first of all, she don't know she's being transitioned out. And so she just thought she was locked out because she couldn't remember her password. But when people are no longer with our organizations, we have to make sure that they can't access the system and go in there and they're not supposed to. So privacy and security, very, very important under the big umbrella of HIPAA. But HIPAA also says that we have in our possession what is known as protected health information, also known as PHI. And as it relates to protected health information, we are only to access, now watch this word, access and release patients' records under three situations. One, treatment. Two, payment. Three, operations. So release of PHI, protected health information, is under treatment, payment, and operation. Now, the one thing you should know about federal government rules is that there are rules and exceptions to the rules. So, for example, do you think the government knows everyone who tested, who knows everyone that is tested positive for COVID to some extent? They know where they live, what state, right? Do you think they know that information? Because how do they get those numbers on the TV that they was showing us every other day?
Yeah.
Yeah, so there are some exceptions. So in a public health crises, um, they got to get that information out. Back in the day, the public health department would go out and visit people. Like, let's say somebody had a sexually transmitted disease, they would try to find them so that they can treat that person as well as treat any partners that they've had, um, so that they can reduce the or decrease the spread of that condition. All right, so we'll talk about HIPAA again, but let's go back to patient intake. Everything we do, we have to be concerned about protecting the privacy and security. So there are four terms that you need to be familiar with as it relates to insurance. And those terms are premium, deductible, co-payment, and co-insurance. I'm going to give you a moment to write those down because I want to talk about each one of them individually. All right. So when we talk about premium, essentially we're talking about the dollar amount that is paid to activate and keep the policy. So, for example, if you have a car, you have car insurance. And with your car insurance, you have a monthly or every 6 month premium. And if you stop paying that premium, you're going to have a lapse in coverage. As it relates to insurance, the premium is really going to vary based upon what type of plan the patient has, whether it's a government plan, a private plan under the umbrella of the private plan, if it's an individual plan, or if it's a group plan. Um, so you may have patients that have a very high premium that they pay monthly or every 6 months, but the costs that they have to pay after that are a little bit lower. After the premium, which is something that is paid to start and keep the policy intact, we have a deductible. The deductible is the dollar amount that the patient must pay before the insurance company will pay for the claim. So I'll use myself as an example. I have United Healthcare, and I have an annual deductible of $1,200. And what that means is my insurance company will not pay any claims until I have paid $1,200. Once I've paid the $1,200, they will kick in and pay a portion of my claim, and I pay the other portion. The other portion is known as co-insurance. That is money that is paid a percentage after the insurance company has paid. So, for example, and I skipped co-payment and I'll come back to that. So, co-insurance, you need to know, is always a percentage. So, for example, with my health insurance, if I have surgery, generally speaking, the insurance company pays 90% and I pay 10% after I've met my deductible. After I've met my deductible. So this is May, almost June, and I think I have paid $200 or $250 of my $1,200 deductible. So unless something happens to me this year, I have two appointments in September, but those are not going to equal $1,000. That means my insurance doesn't make any payments this year. However, what do they get every month? Premiums, just like car insurance. You don't pay a deductible unless you have a car accident, which makes sense, right? Okay, co-insurance again, please remember it is a percentage and it's going to vary. In my example that I gave you, my insurance is a PPO, which we'll talk about that later. And I pay more out of pocket. I pay more monthly so that I can have more choices when I am going to seek healthcare. So, copayment. Copayment is different than co-insurance. Copayment is a small fixed amount, a small fixed amount. And it's going to vary based upon the service that the patient is having rendered. So for example, my deductible, not deductible, my copayment for my internist is less than when I see my lung specialist. Both of those are lower than when I go to the emergency room. If I go to the emergency room, it's $200 for my co-payment. But co-payment, small fixed amount. Co-insurance is a percentage. When a patient is going to have services at our healthcare organization, we must always, always, always verify their insurance. And we need to verify their insurance for every visit. Why? Patients, when they get insurance, they get an insurance card. So, for example, here is a Medicare insurance card. And this is actually an old Medicare insurance card because Medicare stopped putting patients' social security numbers on Medicare cards to protect Medicare patients' identity. So, but anyway, on this card here, you notice that you have an effective date, January 1st, 2018. But nowhere on this card does it say that the patient no longer has the insurance. This is why we have to verify the coverage at each and every visit. Another example could be, and I don't have a copy, but Medicaid. With Medicaid, they have a from and to date. However, there isn't another card that says, hi, I no longer have insurance, and here's my I no longer have insurance card, right? So we have to verify the patient's visit each and every time. Some organizations are a little lazy when it comes to that, and some are not. Here is another example of an insurance card, and this is for one of our commercial payers. And with our commercial payer, you'll notice that looks a little different, but it has some similar information on it. We have on the front who the subscriber is, anybody that's covered underneath this plan. We got some other stuff, their ID number, co-payments, all of that. But then also we have the back of the card that tells us who we should call when we have questions. So when a patient arrives at our healthcare facility, we always want to get a copy of the front and the back of their card. Nowadays, a lot of organizations are using scanners, and the scanners they're fancy because they can put the card in and the card can get the front and the back of the card. Or it could be one of those little cheapy ones where they got to put the card in, it gets the front, and then they got to flip it over, put it back in, and it gets the back. But nonetheless, it still accomplishes the same goal because we have a copy of the card. When patients come to our offices, no matter how long we've known those patients, we still have to confirm that the insurance is the same. Some offices will say, we need a copy of your card. You may be thinking, didn't I give y'all one last time? But this is what we don't remember. Sometimes in the middle of the year, the insurance company will give you a new card just for different reasons. And so you get the card, look the same to you. You get rid of the other one, you put the new card in, don't think twice about it. And it could be that something that you aren't aware of has changed. Maybe your organization was bought out by somebody else, and so maybe the group number changed. It could be something minor that has changed, and you're not even aware of that change, but you get the card, and again, look the same to you. Your name on it, your name is still the same. Your kids is on it, your kids' name still the same. So you're thinking it's all good. Now here's me, Detective Inspector Gadget. I'm like, what's the difference between these two? So anyway, we definitely want to get a copy of the card each and every time because things do change. And critical, front and back. Also, why front and back? Because some insurance companies have a barcode on the back, and some organizations have technology where they can swipe the barcode and actually verify the insurance. And verification of insurance is a term that I think people think, oh, it's not really a big deal. It's a big deal. Why? Yes, you have insurance, but to what extent do you have insurance? What does it cover? How much do you have to pay? How much does the insurance company pay? What do they not cover? Because if we are providing a non-covered service, even though the patient has insurance, if the insurance doesn't cover that service, we got to make a determination as to how the patient is going to pay for that service. Now, some patients have more than one insurance plan, and we want to make sure that we get a copy of all of those cards, front and back, because when it comes time to process the claim, we're going to send the claim to their primary insurance first. After the primary insurance has paid, we're going to then send the claim to the secondary insurance. And then after that, if they have a third insurance, we're going to send it to what is known as the tertiary payer. It's a fancy word for third. All right. Um, Today, we see patients that have two insurance plans, but not a whole lot. Medicare patients sometimes will have a supplemental plan, but a lot of employers are like, well, I'll use an example, my husband and I. My husband has insurance at his job. He does not have me on his plan because they asked a question, and the question was, do I have coverage? And the answer is yes. So since I have coverage, they incentivize them, if you will, to not put me on the plan because I already got coverage. Also, if he tried to put me on the plan, one of the things that they can do is 2021 is double check, fact check that I don't have coverage, because what some people will do is say, well, ooh, your plan is better for this, so I'm going to use your card for this. And it doesn't work like that. If you have insurance, your own insurance is primary, and that other insurance would be secondary. So if my husband did carry me on his plan, my insurance is primary, his insurance is secondary. Now, there are some other rules that apply to this process, and we're not going to get knee deep into all of these processes because, number one, this is not a billing class. This is not a medical coding class. This is medical administrative assistant, even though you will learn and hear some billing and some coding concepts. But this is under no shape, form, or fashion a medical coding program. So in the situation where we have children, there are some rules that we have to follow with regards to who pays first and who pays second. And that is related to what is known as the birthday rule. And the birthday rule says when you have a child that is covered under both parents' insurance, the parent whose birthday, not year, birthday comes first. So, for example, my birthday is April 1st. My husband's birthday is December 7th. He's older than me, but my insurance would still be primary because it's not about the year you were born, it's the day you were born. Now, there's a whole bunch of exception to these rules. So if both parents have the same day of birth, whoever has had their plan the longest, it pays first. If the parents are separated or divorced, whoever has custody, that person's plan is primary. If you have a situation where the one spouse is covered under a group plan and the other spouse is covered under an individual plan, then whoever has the group plan is primary. So let me explain what that is. My husband is employed by a company. he has group insurance plan. I have call up Blue Cross Blue Shield through a broker, and I have an individual plan just for me and my daughter. Um, Mine is not sponsored by an employer, which is why it's not a group. His is sponsored by an employer. Now, as it relates to who pays first, anytime the patient has a government plan and they have a private plan, the government is always the payer of last resort. So, for example, my daughter, who is 29, she's special needs. She's covered under my insurance, but she also has Medicaid. Medicaid pays second because government programs are always the payer of last resort. And they're very clear on that. And they got computers, and the computers are talking to each other. And Medicaid is like, I'm not paying first. United Healthcare needs to pay first. And then we may pay a little bit after that. Big May. As it relates to health insurance and the patient intake process, it is very important that you understand that some services may require pre-certification or pre-authorization. And I'm going to say those terms again. Pre-certification or pre-authorization. When we talk about pre-certification, this is like step one when the patient is having something that's not urgent or an elective surgery. So this is step one. So what happens is a notification is sent to the payer, letting them know that the patient wants to have the service performed, not has had the service, but wants to have the service. Remember, we're talking about non-urgent and elective. So the second part is the payer contacts us and they tell us whether or not they will certify it. If they say no, we can appeal that determination and say, why? Why can't we have this? And they can say no. Again, this is a process, pre-certification, that kind of operates it's a slow process. And depending on the payer, depending on the service, it could take a while. For example, years ago, insurance companies did not want to pay for weight loss surgery because they thought it was elective. But then they realized, oh, if we pay for this weight loss surgery, the patients are going to not have all these medications. And so they win, because if you have all kinds of health problems that cause you to have all these prescription medications, that comes with other stuff, side effects, other problems that stem off of that problem. And so they now know if they pay for you to have weight loss surgery, you'll lose that weight, hopefully keep it off, and they don't have to pay any money because they don't want to pay any money. So that is an example of something that has to be pre-certified. And then what'll happen is they will then next step kind of authorize the service, prior authorization. So usually what happens is they send a letter. I'm going to use weight loss as an example. we approve this patient to have a lap band, gastric sleeve, gastric bypass. We approve any of those, whichever one you want the patient to have. And then what'll happen is, and sometimes they may ask for medical records and all of that just to prove that patient had a medically managed diet for 6 months. And, you know, they better have lost some weight. They not try to just, you know, make the surgery as the out. All right. So after the intake process, the very next step that happens is the provider sees the patient. And when the provider sees the patient, he or she is going to document that service. So let's pause for 1 second. Give me 1 second. I'm going to pull up a medical record. And that's why it's not on the screen because it's kind of big. I'm going to pull up a medical record for you to take a look at. And we're going to talk about that that medical record. So just give me 1 second because I thought I had it right here. And it appears that I don't. Let me pause the recording for a second. I don't like to have dead noise on the recording.
I'm at the bottom.
All right. I'm going to keep rolling because, well, I'll wait a few seconds because in case someone reads slow word.
I'm at the bottom.
All right, everybody have an opportunity to review that note?
Yes.
Okay.
Yes.
So this is an office visit, and as you can see, this patient is a little guy and has diabetes, not that little, but still not grown. But they have diabetes, and their parents are there with them. And they, talk through the history and what's happening and all of that. So this is an office visit. And at the end of the office visit, what happens is the words that reflect the office visit that took place today and the diagnoses that the patient has is converted into a code number. And for the CMAA exam, you must be familiar with these 4 coding systems. And I'm going to pause again and give you an opportunity to write this down. Even though I know you have the recording, I will take some short pauses just for you to write things down. All right, everybody get those captured?
Yes.
Okay. So next, I want to show you some examples of what those codes actually look like. So I'm going to start with ICD-10-CM, and this is for our diagnosis codes. Diagnosis codes can be a minimum of 3 characters and a maximum of 7 characters. And the number of characters that we have are really going to be based on how specific the diagnosis needs to be. So, for example, this code here, B20, this is as specific as we need this code to be. And then here, type 2 diabetes without complications. This one is E11.9. And one of the characteristics of ICD-10-CM is that there are decimal points after the third digit. And a lot of the diagnosis codes actually have more than 3 digits. Then here are some additional ones, and I want you to see here how 1 digit can actually change the code. So for example, F10 is in the alcohol family, and you'll notice F10.20 is for alcohol dependence, uncomplicated, whereas the code that immediately follows it is for alcohol dependence in remission. All right, so again, on the CMAA exam, you're not going to be coding, but you do need to recognize what these codes are or what they look like and what they do. So ICD-10-CM is for diagnosis coding. Then we have our CPT codes. And the CPT codes are 5 digits in length, and they are used to identify what happened to the patient today. What, as in an office visit. What, as in cutting off corns from a person's foot. What, as in an x-ray. What, as in influenza vaccine, or COVID-19 vaccine, COVID-19 test. So CPT shows what happened today. ICD-10-CM shows why something happened. Then we have HCPCS codes. HCPCS codes have several uses. Number one, it covers services that are not captured in CPT. And then sometimes it'll cover services that, like Medicare, will say, no, you can't use that code. We want you to use this Medicare code. And in HCPCS, you see walkers, wheelchairs, canes, medications, contact lenses, hospital beds, gauze, ambulance services, just a variety of services. Then we have ICD-10 PCS. And as you saw on the previous screen, ICD-10 PCS is going to be used for inpatient hospital procedures only. There are no decimal points in CPT, no decimal points in HCPCS, no decimal points in ICD-10 PCS. Only ICD-10 CM has decimal points. after the third character if the code is more than 3 characters. You will also notice that ICD-10 CM codes start with a letter. CPT codes, always 5 characters. They start with a number. HCPCS, they start with a letter. And then ICD-10 PCS, always 7 characters. They can start with a number or a letter, but the letter I and O is not used so that it is not confused with the number 0 and 1. So even though you're not going to be coders, I thought it would be great for you to see coding in action. So I have a video that I did last year that actually I need to redo this year at some point. But it is a video introduction to medical coding. But before I show that video, do we need to take a 5-minute bathroom break?
I like one. Just
Okay.
saying.
Okay, so we
Yeah.
will take a 5-minute bathroom break. Let me put my timer on and we're on break. I'll be back. And in this short video, I really just want to provide a basic understanding of what medical coding is. So in addition to being a healthcare professional for the last 28 years, I've also taught medical coding since 1997. Now, before I begin with this video presentation, I do want to do a couple of disclaimers. Number one, the views that are expressed in this video reflect my personal opinion based on my experience and research. Additionally, during this video presentation, I am going to provide you with a very short walkthrough of the coding process. During this walkthrough, I'm going to be using several coding manuals, one of them which is known as CPT, or Current Procedural Terminology. This code set is owned and a registered trademark of the American Medical Association. So I think the first thing that is important for you to understand is that there are 2 main organizations that actually certify coders. On their respective websites, you can actually view the different certifications that they offer, as well as the requirements for taking those exams. Now, there are other organizations that do offer certification in coding, but if you look at job ads, once you go to their website and see what credentials they offer, you'll see that these 2 are indeed the 2 primary organizations. So I think it's first important to understand the role of the coding specialist and some of the settings that we work in. So number one, a coding specialist is a professional that reviews patient records to identify the diagnoses and the procedures that reflect the services that were provided to the patient. After we identify diagnoses and procedures, using coding manuals, we convert those words into numbers. In terms of the setting, coders can work in hundreds of environments. Some of the most common are the hospital setting, inpatient or outpatient, surgery centers, nursing home, home health. We can also work for emergency departments, rehabilitation centers, insurance companies, and yes, we can work for the government, the federal government, agencies such as the Veterans Administration. In the United States, as mandated by the Health Insurance Portability and Accountability Act, also known as HIPAA, there are 5 code sets that we utilize. Those 5 code sets are the ICD-10 system, which is divided into ICD-10-CM for diagnosis codes and ICD-10-PCS for procedures for the hospital. This is one system. The second is current procedural terminology. The third is the HCPC system. Fourth, current dental terminology. Fifth, national drug codes. In a day-to-day setting, you're going to find that most coding specialists will deal with ICD-10. If they are hospital inpatient coders, ICD-10 PCS, and then CPT is utilized for outpatient hospital services and when we're coding for the provider. HCPCS is utilized for durable medical equipment such as walkers and wheelchairs, just to name a few. So, what skills do you need to have to become a medical coder? So, the first thing that I will tell you is that you have to have a solid foundation in what is known as the language of medicine. So, you must learn medical terminology, anatomy and physiology, human diseases, and pharmacology. You must also become familiar with the health record and the different forms that are in the health record. Healthcare is a heavily regulated industry, and so you must be familiar with some of the most common regulations that we are required to follow. The medical record is documented by a healthcare professional, and sometimes the record is unclear or it's incomplete, and we have to query the physician or the provider for clarification on what's documented in the record so that we can ensure that we assign the most accurate codes to the patient's encounter. A coder specialist has to be detail oriented, must be able to communicate. We also have to have analytical skills. You have to be a researcher. You have to be an independent thinker, and you have to have computer skills. Now, after saying all of that, let's talk about the role of the coding specialist with a demonstration. So, for purposes of our demonstration, we have an established patient that is seen in the office for a chief complaint of shortness of breath and fatigue. The physician performs a detailed history, detailed examination, and medical decision making is of moderate complexity. The final diagnosis is pneumonia, and in the office, the physician provided and interpreted a 2-view chest x-ray. So, as part of the coding process, in addition to all the skills that I mentioned, each of our code sets has different rules and regulations. So let's first talk about the patient's diagnosis. The patient came in with shortness of breath and fatigue. And once the physician performed the office visit services, also known as evaluation and management, the physician determined that the patient had pneumonia. So, in the United States, the code system that we utilize for diagnoses is called ICD-10-CM. So, this is an ICD-10-CM manual, and what I'm going to do now is walk you through the process of actually locating a code. So, first up, the coding process begins in what is known as the alphabetical index. And for this patient, our diagnosis was pneumonia. So the index is sort of like a dictionary because the terms in the index are in, again, alphabetical order. And so here you'll notice the word pneumonia. Now, in our documentation, and let's go back to our documentation so you can see,
we do not have any further specificity about the pneumonia. And so our index is giving us a very generic code of J18.9, which is the basic code for pneumonia without any further specificity. So the next part of this process requires me to verify the code that I have identified in the portion of our manual that's known as the tabular list. And the tabular list is also in a particular order, and here it's in alphanumerical order. So notice J18.9 says pneumonia, unspecified organism. All right, so now that I have identified my diagnosis codes, I now must go back and identify the procedures and services that were provided. So I'm going to now take out my other code manual, which is CPT, or Current Procedural Terminology, which again is a registered trademark of the American Medical Association. In the CPT manual, there is also an index, and so I'm going to start there. And for purposes of this demonstration, I'm going to go a little backwards in terms of how I select the code. I'm going to start with the easiest code first, which is my X-ray. All right, so let's get that focused in so you guys can see it. All right, so I'm going to start with the main term of X-ray. And because this was a chest X-ray, I'm given 71045 through 71048. And let me dim this light a little bit so you can see. So again, chest 71045, 71048. Now you'll also notice under chest, there is mention of computer aided detection, but our patient didn't have that documented in our record, so we can't code what was not documented. So my index is telling me to look up these codes. So then the very next thing I must do is go back to the what's known as the tabular or numerical list of the code manual, and I'm going to be looking for the chest X-ray codes, and let's see here what we have. So now by the time you do all that turning, you're like, wait a minute, do you remember what type of chest X-ray it was? So let's go back and take a look. To view chest X-ray. Now for this demonstration, I'm making this process very straightforward, so I don't want you to think, wow, that's pretty easy. I made this demonstration so that you would have a basic understanding of what medical coding is, and then keep in mind, medical coding is not billing. In order to submit a bill to the insurance company, we have to have codes first. And of course, in order to have codes, we have to have documentation. And before we have documentation, we have to have the patient encounter. All right, so 71046 is for a radiologic examination chest, and this was 2 views. So that's our final code for that. So now the other service that we want to select, and this is actually our primary service, is that the patient was an established patient in the office and the physician performs a detailed history, detailed exam, and medical decision making was of moderate complexity. So in my CPT manual, I have to go back to the index, and this time I'm going to capture the code for the office visit. All right, so let's see what we got going on here. All right, so with the office visit codes, and what you're going to notice is, trying to get that light here. All right. So for the office visit codes here, you're going to notice that they're divided into a variety of categories. We want office visit, established patient, the index is giving us a range of codes of 99211 through 99215. So basically what that means is in that range of codes, one of those codes is actually our final code. So, and our codes are going to be selected based on what's actually documented in the medical record. All right, so here we have our office visit codes, and the very first one (99211). This is established patient in the office. This is generally what we call a nurse visit, so I'm going to skip on past that. Now, do you notice with the codes underneath them, they're indicating problem focused history, problem focused exam, straightforward medical decision making? These are actually what are known as components for a service. So let's go back to our documentation because we need to see, what did our provider document? Well, they documented a detailed history, detailed exam, and the medical decision making was of moderate complexity. So our job as the coding specialist is to figure out, well, which code provides that content. So I'm looking at the different codes, and here I see 99214, office visit, detailed history, detailed exam, moderate complexity medical decision making. So for this particular patient, I have 3 codes, 2 CPT, 1 ICD-10-CM. I have 99214 for the office visit. I have 71046 for the chest x-ray. I have J18.9 for the pneumonia. Now, there are some other little nuances that go with the code assignment for this encounter, so I'm not going to get that deep, but this essentially is what coding specialists do all day. Now, if you want to know more about the coding process, all right, you don't need to know more about the coding process right now because you are trying to become a CMAA. So, but hopefully you got just a brief understanding of what the person actually does, right? Okay. So since I recorded that video, I've upped my recording studio game. So now I know about the lights because that's a whole process by itself. All right, so the last thing that I wanted to cover today, and let me put my screen back up, is I wanted to talk about some of the forms that you're going to see during the registration process. So number one, we always have to have a consent for treatment because we should not be providing services to patients unless we have their consent. Now, when we get to the compliance chapter, we'll talk about the different forms of consent because sometimes it's an emergency and we make the assumption that the patient is wants to be helped, or if a person goes to get a blood draw and they stick their arm out, that means that, it's okay. But we still ask them, is it okay if we draw your blood? All right. And we say, like, what arm do you want it in? That further clarifies that they want it done. Then sometimes we will give, if it's a new patient, we'll give them like a history form. And you've seen this. Have you ever, or do you currently have, and they give you this whole list and you say, yes, no. If you say yes, what the doctor is supposed to do is to ask you some more questions about that yes. One of the things I will tell you that is so very, 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 very important is really helping your family understand the importance of being actively involved in their healthcare, knowing that as patients, we have rights. We have rights to see our medical records. We have a right to access the patient portal and all these tools that we have. And oftentimes people don't realize as patients that we have rights, but we do have rights. All right, HIPAA says that we have to give the patients a notice of privacy practice. And basically, the notice of privacy practice just tells the patient how we're going to use their information, treatment, payment, and operation. So, we tell them that. Usually we have the patient sign off on the fact that we've given them this notice of privacy practice every year. Some, if you go to the emergency room, they may look in the system and see when the last time you got it. Some places I've seen give every visit, but that's kind of a waste of paper. They should have this notice posted somewhere on their website, in the waiting room. Next time you go to the office, just look around and like, where's that notice of privacy practice, just to see if they have it. Then we have the release of information form. Release of information is the patient acknowledging that it's okay for us to release their medical records to an insurance company. That's for payment. Operations, maybe we need to do an audit. And then treatment, we may need to send their record to somebody else, and that's a part of the treatment process. So this is the patient acknowledging that it's okay. Then we have our financial responsibility form. This is important because we want the patients to know we got rules. If you cancel less than 24 hours, you're gonna pay $30. If you don't show up, you're gonna pay $100. Whatever our rules are, we're gonna give them that. But then also, if there are some services that our doctor, who is a specialty, may perform that the insurance company may not pay, we have the patient sign off on the fact that if your insurance company doesn't pay, you agree to pay us. Then we have a form called assignment of benefits. It's not always a separate form, but I separated it out because I want to make sure that it's clear that you know what that is. And assignment of benefits goes like this. Assignment of benefits is the patient saying they agree that the money that we earn today for providing the service goes to us and not to them as the patient. Because sometimes the insurance company will send the check to the patient instead of us. And then we got to try to fight with the patient to actually get the money back. And if they don't pay us, we can report that income to the IRS because it is money that they have earned. So patients think, ooh, I got me a $2,000 check. I'm gonna go shopping with this check. You did not provide the service that resulted in earning the payment, and so you should not keep the money. Advance directives. These are where the patient makes known in advance what their wishes are in the event something happens to them. And unfortunately, this is one of those areas that I feel that in some minority communities, we just think we're gonna live forever. So we don't tell nobody what we want. And not just tell somebody, but write it down on paper. My father, who had a stroke maybe 2 years ago, I'm like, hey, Dad, you need to, put your wishes in writing. Because number one, I'm not about to fight with my brothers and sisters. I don't got time to do that. But unfortunately, when people die, as we all know, that brings out the worst in people and it brings out the best in people, usually the worst. And I luckily have not had a lot of people die in my family. And when we have had deaths, most of the time it's some people that's not even family members that's causing all the problems. But anyway, this just really tells the doctors how they want their care to be done. So for example, power of attorney. My cousin, my second cousin, my father's first cousin, my second cousin, I'm her medical power of attorney. And what that means is if she gets to a place where she can no longer answer questions for herself, I am the person that that they would go to. Now, it's good and it's bad. It's good because I'm gonna honor her wishes. It's bad because I know my cousin, who I guess would be my third cousin, he not gonna want his mama to die, right? So he's gonna be the one who is gonna be trying to have a fight with me about his mama and them resuscitating her. And then I'm just gonna pull out my paper and say, hey, your mama, she put me in charge. Then he probably gonna act crazy and I'm gonna have to call my husband. But that's a whole other story because I already know how it's gonna go down. So I'm prepared for that day because it's just unfortunate. But I tried to get my father to put his wishes in writing. He's like, well, when you call a doctor, I tell them to call you. That's not enough. I need you to. So it's like an every week conversation that I have to have with him. All right. So another form that we see in the doctor's office setting a lot is called the encounter form. And the encounter form is where we capture the CPT code and the diagnosis code that was captured today. And this is a situation where maybe the doctor doesn't have a coder, and so they circle their own codes. The problem with this approach is that doctors don't know coding. They oftentimes make mistakes when they circle and stuff because they don't know all the rules. Generally, coders go to school from anywhere from 6 months to a year, and doctors get, an hour discussion about coding. So anyway, this encounter form captures the CPT codes, the diagnosis codes, and we might put in the patient's copayment and stuff like that. Also in the forms, we have referrals. And when you have a patient who has an insurance called an HMO, the HMO requires that if they go to a specialist, that they have to get a referral from the primary care physician. The primary care physician is like the gatekeeper. And unless he says the patient can go and see a specialist, that patient who has that HMO got one or two options. They can go see that specialist and pay for it themselves, or they don't go. Because HMO, it's not better to ask for forgiveness. You need to get that approval in writing. And one of the reasons that they have this HMO business in the first place is to decrease costs, but also to give the patient a provider that they can, call their own. All right, the last thing we're going to talk about today is really about planning for the next visit. So whenever a patient is on our schedule to come in today or tomorrow, one of the things that we have to do is get the records ready. So let's say today we saw a patient. End of the day, we are going to make sure everything that should be in the records are in the records. Any reports that are missing, that haven't been signed, haven't been looked at, we want to make sure that we get those to the provider and get them to sign off on them. And then we need to store our files properly. So storing the files properly can be in a file cabinet. It could be on a filing shelf. But if it's in electronic health record, that filing process, if you will, is not something that we need to do unless we have medical records that or documentation that has to be scanned into the patient's record. But if we're talking about a paper-based system, and unfortunately, on this exam, some of the questions that they ask you are about paper-based systems. So we're gonna cover something tomorrow that you're gonna say, "Oh, that's kind of boring," but it is a paper-based system of how we file our medical records. So when we have a situation where we have paper records and we have patients that are coming in over the next couple of days, one of the things that we have to do is get those records, look in there. Why is our patient coming in tomorrow or the next day? If there's laboratory tests that they were supposed to have, do we have the laboratory tests? If we don't, we need to call the patient. Did you have the test? Patient says no. Based on our policy, we have to make a decision. Do we need to reschedule that patient? Because if the visit was solely for that test, if they haven't had the test, what are we going to talk about? So we make sure that everything is ready for that next day. Now, when we're locating the patient's charts, there is always going to be, in the paper world, there's always going to be some type of filing system. And these filing systems we're going to talk about tomorrow, but they can be in alphabetical order, so ABC order, or these really funky numbering system orders that we'll talk about tomorrow, right at 12:30 when you're nice and fresh, because you're going to say, huh? What kind of system is this? But it's either alphabetic or it's numeric. Now, in those settings where the patient or where the doctor has paper records, like my lung specialist, he's the best lung specialist. I've had 3. It's the best. He said he will never, ever, ever, ever again have electronic records. So they got paper records just stacked up everywhere. And so what they did recently, I don't know if it was COVID related, maybe it wasn't because it was about 3 years ago. They kind of organize their records. So the approach that they do is like many other offices is they have active records. And active records, those are patients that are currently receiving treatment. Then you have the inactive records. Those are the patients that we haven't seen in 6 months or longer. Of note, every facility gets to decide what their definition of inactive is. But for this exam, inactive is somebody we haven't seen in 6 months. And, you know, when you have patients that have lots of health problems, those records, you can have volume 1 of 10 because, you know, they got all that paper and different reports and history. And then the closed files, those are for patients that died, moved away, or, you know, they quit us, you know, they stopped coming. All right, so that was patient intake. A little bit more exciting than what was yesterday? Scheduling. And so tomorrow we're going to talk about office logistics. And office logistics, I think, is the chapter that a lot of people say, oh, I know about this stuff. So shouldn't be too bad. And tomorrow, what's tomorrow? Wednesday. This week is going by so slow. All right. So before we go, any questions? And Mr. Pugh is not here today. I wonder, how does he do attendance? I'm going to take a picture of the roster of people who are here today and text it to him. In case some people left out of here, was here and not here. So I'm going to get this to him. But does anybody have any questions?
No.
No, I'm good.
Okay. Y'all look like y'all bored. Y'all want to come in the office and do some work.
No, thank you.
I thought I asked. All right. Well, I will
Pressure.
upload this recording to the same place. I saw one person watch the video yesterday. So I will upload this recording to that same place, and everybody have a good afternoon. See you tomorrow.
You too now.
Thank you, and you have a great afternoon.
Thank you. Have a great afternoon.
Thank you. You do the same.
Yeah.